Estou dando querer.
Hi, everyone. I've done very little sharing tonight so far. Okay, I thought I would leave it to you tonight because we have a lot to cover. And also, there's been considerable promotion before we've come on. So, it's nice to see you. Hi, Lana. Lana says, howdy all from Minnesota before we start. And thank you for being here. Please remember we all need to contact our elected officials, regardless of what side of the political aisle they are on, in whatever form on this. And there's Dolores. Hello, Dolores. And Kay. Hi, Kay. And Anthony. Hello. Thank you for coming. Okay. And Bonnie is here somewhere too. So thank you for coming, Bonnie. So I'm going to start. And where I'd like to start is, first of all, with the idea, which I've noticed some people saying, that the introduction of the new Medicare for All bill was merely performative because really people don't expect it to pass. And so therefore introducing it again is not really significant. It's just a symbolic thing to do. And what the progressives needed to really do was to have another force to vote campaign, and this time a serious one. Hi, Terry. Or words to that effect. I don't mean to quote anybody specifically in particular, but those are some of the remarks, okay, that I've been seeing. Well, from my perspective, what I have to say about that is there's certainly an element of performance in this, but it's also true that if you don't get a bill introduced and are not working on getting that bill through, then whatever else you do with respect to Medicare for All is really performative, because the only way bills do get through the Congress is to introduce them first and to begin to work on them. So it does seem to me that this is certainly a serious bill. I think by and large it's a very good bill, as we shall see. And I also think it was very good, okay, of Jayapal to work so hard on it, to introduce it with Debbie Dingell, to assemble 113 co-sponsors for it at this point. And so kudos to her. kudos for the introduction and the town hall video, okay, a few nights ago, or a few days ago, I should say, okay, at 12 noon. That was pretty well done, I thought. There was a considerable degree, okay, of enthusiasm. It was a really good way to start off. They did make certain gains, as we shall see. And I now am going to get into the details of the bill for you. But first, I do want to point out that what I've done is to leave you some links. The first of the links is the draft of the bill itself that was introduced by Jayapal and that has been sent to the printing office. Okay. It is that draft that I will be referencing, sharing with you, and speaking about. Secondly, I've left you a link to the page at congress.gov that the bill, the text of the bill, is going to be on. As of earlier today, when I looked at it, the text of the bill had not arrived there. So all we have to refer to is the bill that Jayapal has on her site. I don't think there are going to be any changes to that, but when you go to the congress.gov page for the bill, okay, the link to which, again, I've given you here, you will find that the number of the bill is H.R. 1976. So, till recently, we were referring to H.R. 1384, which was the number of the bill in the 116th Congress. Now, the new number of the bill is H.R. 1976 for the 117th Congress. So I thought you ought to know that. And I have links both to the text of the bill as it now stands and to the page that will eventually have the text, most probably by this Monday. I also left, a couple of other links. One is to a summary of the contents of the bill that compares it to the present state of affairs. That summary was done by pnhp.org, and I've left you a link to that. And actually, I'm going to start off tonight by sharing that as background to the text. And finally, I've left a link to an article on The Intercept, which is the article from Deconstructed. Okay, it's a Ryan Grimm a piece based on interviews that he has done for the Deconstructed podcast that he does. And that is on the Medicare for All Bill 2. And that's the final thing that we're going to go over. So what I want to start off with sharing is the summary from pnhp.org. And there it is. You should be seeing it now. On your screens. So I'm going to go over that with you. So it starts off by pointing out this is a comparison of commercial insurance versus the Medicare for All Act of 2021. And it starts off, the health insurance industry and their friends in Congress say that commercial insurance products, including the ACA marketplace, the workplace, and privatized types of Medicare Advantage plans, are the best way to cover uninsured Americans. But how do these plans compare to Medicare for All? And of course, in the context, this is a comparison to the Medicare for All Act of 2021. And they give a nice handy little table and some questions and some answers. Does it provide secure coverage for everyone in the United States? For commercial insurance, the answer is no. Coverage depends upon your job, your marriage, or income, and can be lost at any time. More than 30 million Americans are uninsured, and 40 million have high deductible plans they can't afford to use. I believe that's incorrect, that it's been some time since, well, technically more than 30 million Americans are uninsured, but I think right now the figure is more like 55 to 60 million Americans, because a whole bunch of Americans lost their coverage during the time of the pandemic when they were severed from their jobs. Now, under the COVID-19 relief bill, I guess they'll be able to get coverage using a COBRA, which they were not able to afford before. So maybe very shortly they'll be getting on again. But I think the number of uninsured had gone up to 55 million or 60 million based on various estimates, that I had seen. So that figure of 30 million gives a gross misimpression of how much of a crisis we were in. Anyway, the comparison to Medicare for All is, yes, it covers everybody in the nation, regardless of age, employment, income, or immigration status. Coverage is guaranteed for life. That's a bit of an exaggeration because it covers people who are residents of the United States. It's unclear whether it's going to cover people who are not actually legal residents. Though I think that in the new bill, that is in the discretion of the secretary, that the secretary is free to cover everyone who tries to register. And I think that will be done in the interests of protecting everyone in case we have another public health crisis. Anyway, going on. Does it cover health services for all parts of the body? For commercial insurance, no. Most plans do not adequately cover the full range of needed health services, forcing families to either skip care or pay for it on their own. And then PNHB says, of the Medicare for All Act, yes, it covers all medically necessary services, including hospital and doctor visits, dental, vision, hearing, mental health, and reproductive care, long-term care, ambulatory services, and prescription drugs. Yes, that is absolutely correct, as we shall see. Does it include free choice of doctor and hospital? For commercial, no. Patients cannot see doctors or hospitals outside of the insurer's network, quote, unquote. Yes, patients are free to choose practically any hospital or provider in the nation, That is technically correct as long as the hospital or provider is willing to register with the Medicare program as an official hospital or provider. I expect, and everybody expects, that 99% of the hospitals and the providers are going to register with the Medicare for All program, because that will be the only way they can make a living. There are very few doctors who will be able to make a living outside of the network of 99% of the providers who are going to have to go along with the program. Does it reduce health costs for most families? For commercial insurance? No. Insurers pass on costs via premiums, copays, and deductibles that discourage patients from seeking care. And for Medicare for All, under the new act, yes, care is provided free at the point of service. Families will never see a medical bill again. It's true. Does it reduce national health spending? No. Insurers have no incentive to reduce health spending, since they pass increased costs on to patients, employers, and taxpayers. This statement about commercial insurance is absolutely true. There are no cost controls currently in the private health insurance plans. And for Medicare for All, yes, by eliminating insurance profiteering, reducing providers' administrative costs, and by negotiating drug prices, it will save at least $700 billion a year. I personally think that's a conservative estimate. I have often said, and I still believe, that I think it will save, once it gets fully implemented, that it will save 1/3 of what we spend now. In this year, in the 2020 year, the projection is that, I don't think the figures are fully official yet, that we spent $4 trillion. So, if we assume we're going to save 1/3, we would be at roughly $2.7 trillion as opposed to costs of $4 trillion. And that means that we'll save $1.3 trillion per year, which works out to $13 trillion over 10 years. So it's 7 trillion versus 13 trillion. And that's still probably a conservative estimate. We would still be less efficient, than Canada if we only saved 1/3. And I think we're likely to reach the same efficiency, as Canada, which means we'd probably save 14 or 15 $1 trillion over 10 years, rather than just the 13. But here we are. Next, does it improve health equity? And the answer for commercial insurance is no. People of color are less likely to be insured. Copays and deductibles create financial barriers to care, exacerbating disparities. And for Medicare for All, for the new act, their answer is yes, it eliminates all financial barriers to care and invests in health services and facilities for underserved urban and rural communities. And that is, again, absolutely true. That is something that's not being done by the private sector right now, and being done too little by the government, which is supporting facilities somewhat, actually supporting or subsidizing private sector spending on facilities. Uh, so yes, there'll be much more investment in health services and facilities for underserved communities if the Medicare for All Act is passed. So that's the summary from PNHP. Largely an accurate summary, I think. Where I disagree, I've given some commentary. Let's now go over to the text of the bill itself. So let me share my PDF copy of it. Which I've highlighted, in various places. You'll notice I edited the PDF and I put in the number right at the beginning, HR 1976. Uh-oh. I see that hasn't been shared yet. So hang on a second and let me make sure it got shared. Sorry about that, folks. Not even sure my summary got shared, which is quite annoying. Hang on, I'm getting it. There. Okay, you should be seeing it. Please let me know if you're not. Seems to be showing up on your screen, so. Let me continue on. Okay, I see it's on your screen, honey, so that's good. Okay, so let me note in Section 1, the short title of the bill says this act may be cited as the quote, the Medicare for All Act of 2021. I'm not aware of any other official title, at this point. Title 1 in this bill is establishment of the Medicare for All program by universal coverage enrollment. And then I'm just scrolling down, table of contents, where I've highlighted the parts that I'm going to cover. I'm not going to read those off. I'm just going to slowly scroll them and then go to Title 1. So, there's hereby established a national health insurance program to provide comprehensive protection against the costs of healthcare and health-related services in accordance with the standards specified in or established under this Act. Then Section 102 says, in general, every individual who is a resident of the United States is entitled to benefits for healthcare services under this Act. The Secretary shall promulgate a rule that provides criteria for determining residency for eligibility purposes under this Act. So it's going to be up to the Secretary to specify the legal residency rule for this particular Act. It's going to be different from what might be a legal residency from the point of view of a U.S. court. In other words, undocumented people may be covered under this bill depending on what the Secretary decides. It would be wise if the Secretary would decide to just include everyone who registers with the program and who shows up for service. Because public health is involved, and as experience in the pandemic is now showing us, it is dangerous for all if there are people who are not able to get treatment, whether they happen to be legal residents or not. Anyway, Part B under Section 102, treatment of other individuals. The Secretary may make eligible for benefits for health care scroll down too fast. For healthcare services under this Act, other individuals not described in subsection A, and regulate the eligibility of such individuals to ensure that every person in the United States has access to health care. So I think this text here makes it clear that the intention is to service every person in the United States. We don't want anyone living here who cannot be serviced under this program. The danger of having that condition is recognized in this language. In regulating such eligibility, the Secretary shall ensure that individuals are not allowed to travel to the United States for the sole purpose of obtaining healthcare items and services provided under the program established under this Act. So there will be some rules and regulations that stop people from specifically coming here from abroad and then trying to get services because they came here only for such a purpose. I don't know exactly how they're going to do that. It may not be the easiest thing in the world, but the important thing is that everybody who is inside of the country can get access to services, at least for keeping us all safe. Section 103, freedom of choice. Any individual entitled to benefits under this Act may obtain health services from any institution, agency, or individual qualified to participate under this Act. So that's where I say 99% of the providers are going to accept patients under this Act. Section 104, non-discrimination. In general, no person shall, on the basis of race, color, national origin, age, disability, or marital status, citizenship status, primary language use, genetic conditions, previous or existing medical conditions, religion or sex, including sex stereotyping, gender identity. Sorry, I skipped down too quickly. Sexual orientation and pregnancy and related medical conditions, including termination, of pregnancy, be excluded from participation in or be denied the benefits of the program established under this Act, except as expressly authorized by this Act for purposes of enforcing eligibility standards described in Section 102. So that's a pretty strong statement saying that no one will be discriminated against on any unreasonable basis. Continuing, or be subject to any reduction of benefits or other discrimination by any participating provider as defined in Section 301, or any entity conducting, administering, or funding a health program or activity, including contracts of insurance pursuant to this Act. And then the next segment, claims of discrimination. Segment B, Clause B, I should probably say, specifies the Secretary shall establish a procedure for adjudication of administrative complaints alleging a violation of subsection A. So there are going to be courts to adjudicate that, administrative courts. It says any person aggrieved by a violation of subsection A by a covered entity may file suit in any district court of the United States. Well, I guess it will be in federal courts, district court, having jurisdiction of the parties. A person may bring an action under this paragraph concurrently as such administrative remedies as established in paragraph 1. And the court may grant compensatory and punitive damages, as well as declaratory relief, injunctive relief, attorney's fees and costs, or other relief as appropriate. And then there are some more technical aspects that are stated, which I'm not going to read through. Section 105 is on enrollment. In general, the Secretary shall provide a mechanism for the enrollment of individuals eligible for benefits under the Act. Include a process for automatic enrollment of individuals at the time of birth in the United States or upon establishment of residency in the United States, and provide for enrollment as of the dates described in Section 106 of all individuals who are eligible to be enrolled as of such dates, as applicable. Of course, we'll shortly get to Section 106. So you can see what it says. There will be issuance of universal Medicare cards. Everybody is going to get a Medicare card. The card shall not include an individual Social Security number. So there will be another identifier, but the card will be for purposes of identification and processing of claims for benefits under the program. Here is Section 106, the effective date, of benefits. In general, except as provided in subsection B, which we will get to just a moment. Benefits shall first be available under this act for items and services furnished 2 years after the date of the enactment of by this act. So, if the enactment of this act is in July of 2021, for example, then benefits shall first be available in July of 2023. So there will be a wait for the majority of people of 2 years to be covered. Then subsection B says coverage for certain individuals. Clause 1. In general, for any eligible individual who, A, capital A, has not yet attained the age of 19, as of the date that is 1 year after the date of the enactment of this act. 1 year is July 2022 in the example I'm using. Or B, has attained the age of 55 as of the date that is 1 year after the date of the enactment of this act. So again, that is July of 2022. The benefits shall first be available for this act, under this act, for items and services furnished as of such date. So, for 55 and over, and for 18, and younger, from 0 through 18. In other words, services, products will be available as of June 2020, as of the beginning of July of 2022. So there's a 1 year wait for the elderly, 55 and over, until the act kicks in, and a 2 year wait for others, though not even entirely then, as we shall see, because in subsection 2, there's an option to, there's an option to continue in other coverage during a transition period. We'll go more deeply into the transition period later when we get to that section of the bill, but this section talks about the option. Any person who is eligible to receive any benefits as described in paragraph 1 may opt to maintain any coverage described in section 901, private health insurance coverage, or coverage offered pursuant to subtitle A of Title 10, including the amendments made by such subtitle until the date described in subsection A. In other words, that people have the option of keeping the insurance they have now until by 2 years after the enactment of the bill. So that's the end of the transition period. Yes, Bonnie.
Is that considered concessionary?
I'm sorry?
Is that considered a different kind of pay for concierge?
No, that is not concierge services. It just means that people will be able to keep the private insurance they have now or the insurance they have under the Affordable Care Act, okay, or the insurance they have now, I suppose, under traditional Medicare, um, until the 2-year transition period, okay, is over. Okay, if they opt to do that, okay, that's the option, or one of the options. As we'll see, there's another option too, but we'll get to that later. Section 107 is a prohibition against duplicating coverage. In general, beginning on the effective date described in Section 106A, it shall be unlawful for a private health insurer to sell health insurance coverage that duplicates the benefits that are provided under this Act, or 2, an employer to provide benefits for an employee, a former employee, or the dependents of an employee or former employee that duplicate the benefits provided under this Act. So no duplication after the 2-year transition. No more duplication. But nothing in this Act shall be construed as prohibiting the sale of health insurance coverage for any additional benefits not covered by this Act, including additional benefits that an employer may provide to employees or their dependents, or to former employees or their dependents. So, for example, cosmetic surgery is not covered in this Act, generally speaking. So, it would be possible for people still to buy from private sources health insurance covering cosmetic surgery, if such was needed. Okay, or other services that are not covered. However, now we come to Title II. Comprehensive benefits, including preventive benefits and benefits for long-term care. Section 201, comprehensive benefits. In general, subject to the other provisions of this title and Titles 4 through 9, individuals enrolled for benefits under this Act are entitled to have payment made by the Secretary to an eligible provider for the following items and services if they're medically necessary or appropriate for the maintenance of health or for the diagnosis, treatment, or rehabilitation of a health condition. 1, hospital services, including inpatient and outpatient hospital care, including 24-hour-a-day emergency services and inpatient prescription drugs. 2, ambulatory patient services. 3, primary and preventive services, including chronic disease management. So, for example, if you have something wrong with your back and it's chronic, okay, you would be entitled to services. Now, presumably, the services of a chiropractor. Even if you have a chronic condition. On Medicare right now, you're not entitled to the services of a chiropractor if your condition cannot be actually cured by the chiropractor. 4, prescription drugs and medical devices, including outpatient prescription drugs, biological products, okay, and also medical devices. What's included under biological products? I don't know. But it seems to me marijuana is a biological product. Just saying. Just saying. If the Secretary is going to be able to determine the list, okay, of biological products, that's included within that particular category, it looks like, based on the language of the bill, it will be within the authority of the secretary to make but THC products and CBD products covered under this bill, as long as they're prescribed by a doctor. Number 5, mental health and substance use treatment services, including inpatient care. 6, laboratory and diagnostic services. 7, comprehensive reproductive, maternity, and newborn care. 8, oral health, audiology, and vision services. I interpret that as dental, hearing, and vision services, eye care services. Number 9, rehabilitative and habilitative services and devices. 10, emergency services and transportation. Number 11, early and periodic screening, diagnostic and treatment services as described in sections, and then it gives a whole raft of sections of the Social Security Act and the section of the U.S. Code of a number. There are a number of other sections of the U.S. Code that are referred to here. I'm not going to go into the detail of the U.S. Code for you. Subsection 12, necessary transportation to receive healthcare services for persons with disabilities, older individuals with functional limitations, or low-income individuals as determined by the secretary. So in other words, the government is going to pay for transportation of certain people who have problems getting around. 13, long-term care services and support as described in Section 204, which we'll get to shortly. We'll get to Section 204 and describe those. 14, hospice care. These are services not covered now. Long-term care services and support, hospice care, not really covered now. Not without considerable burden on the people trying to get them, like forcing people into near bankruptcy before they can get those services. Number 15, services provided by a licensed marriage and family therapist or a licensed mental health counselor. Next is a provision for revision of the benefits based on changes in medical practice or new information from medical research, okay, or new kinds of technology, okay, based on recommendations from various authorities in the field. The secretary will be revising what is covered, okay, and what is not. But the recommendations that are tendered may not include a recommendation to eliminate any benefit. So in other words, the specifics of benefits will be added, but no recommendations can be made to subtract any benefits. Those are illegal under the bill. C refers to hearings. In general, the Committee on Energy and Commerce and the Committee on Ways and Means of the House of Representatives shall not less frequently than annually hold a hearing on the recommendations submitted by the Secretary under subsection B. Now, under section 2 of this rulemaking authority section, or I guess it's called subsection 2, I'm confused about what's a section and what's a subsection. I think this is probably a clause. But anyway, clause 2 is the exercise of rulemaking authority. But paragraph 1 is enacted as an exercise of rulemaking power of the House, of Representatives, and as such shall be considered as part of the rules of the House. In other words, this assignment of hearings authority to the Committee on Energy and Commerce and the Committee on Ways and Means, and the stipulation that they're to have annual hearings, at least annual hearings, on the recommendations submitted by the Secretary. This would become a part of the rules of the House, and such rules shall supersede any other rule of the House only to the extent that rule is inconsistent therewith. And B, with full recognition of the constitutional right of either House to change such rules, so far as relating to the procedure in such House at any time, in the same manner and to the same extent as in the case of any other rule of the House. So then, Clause D deals with complementary and integrative medicine. Subsection 1 says, in general, in carrying out, subsection B, just above, I guess that is, the Secretary shall consult with the persons described in paragraph 2 with respect to identifying specific complementary and integrative medicine practices that are appropriate to include in the benefits package. Identifying barriers to the effective provision and integration of such practices into the delivery of health care, and identifying the mechanisms for overcoming such barriers. Then it gives a list of who the Secretary shall consult with. I'm not going to go through this list. It's very long. And of course, it favors the providers of complementary, integrative medicine and other stakeholders in this area. So it's a useful specification of who the Secretary shall consult with. It also says next in subsection E that states may provide additional benefits. Individual states may provide additional benefits for the residents of such states as determined by such states, and may provide benefits to individuals not eligible for benefits under this act at the expense of the state, subject to the requirements specified in section 1102, which we'll get to sometime later. Section 202 says, in general, the Secretary shall ensure that there is no cost sharing, including deductibles, co-insurance, co-payments, or similar charges is imposed on an individual for any benefits provided under this act. So again, no deductibles, no co-insurance, no premiums, no co-payments, no nothing to be imposed on an individual with respect to any of the benefits that I just listed. Subsection B under section 202. No balance billing. No provider may impose a charge to an enrolled individual for covered services for which benefits are provided under this act. You won't receive another balance bill in your life if this is passed. No prior authorization either. Benefits provided under this act shall be covered without any need for any prior authorization determination and without any limitation applied through the use of step therapy protocols. So none of this stuff where you go through a particular therapy and you get authorization for the first step, then you have to go back and get authorization for a second step and a third step and so on. That's not going to happen. You're not going to need any authorization. You just go through and you get the service as long as it is approved under the Act. Section 203, exclusions, and limitations. In general, benefits for items and services are not available under this Act unless the items and services meet the standards developed by the Secretary pursuant to Section 201A. So in other words, if it's not listed previously in items 201A and is not covered by the standards of the Secretary, then benefits will not be available. Subsection B, treatment of experimental items and services. 1. In general, in applying subsection A, the Secretary shall make national coverage determinations with respect to items and services that are experimental in nature. Such determination shall be consistent with the national coverage determination process as defined, and then it gives some sections from the Social Security Act. There is an appeals process. And it says the Secretary shall establish, an appeals process, and as much as is possible, shall follow the process for appeals under the Medicare program described in Section 1869 of the Social Security Act. And it gives the provision of the U.S. Code, and so on. So, now, up to this point, we've gone through 15 pages of the bill. It's a 130-page bill. So by page 15, it's described what are the benefits under this bill. And if you have benefits from Medicare now or benefits from private insurance, you should already be aware, based on what I've gone over, how much more comprehensive this bill is and how much more freedom it gives you to get health care than you have now. It should already be obvious. If it's not, you have the link. Go over this list again. Read it 2 or 3 times. Nothing that I personally get now or can think of getting is excluded by this list, of benefits. It goes by the name, of Medicare for All, but it is much more comprehensive than Medicare for All. Did you have a question?
Yeah.
Much more comprehensive than the current Medicare Act.
So it won't do transplants. It won't do facial needs, no nose, brain coverage.
If these needs, are medically necessary and appropriate, yes, it will do them. In other words, it's only where if you need something that's purely cosmetic, that it's not going to cover it. But if you need cosmetic surgery because you've lost your nose because somebody cut it off, yeah, you're going to get that.
There are children born with no nose.
They'll get that. That will be available. Anything medical science can do for them will be available in a situation like that. Okay. There is no problem based on what I read off.
So it won't do transplants.
Much more comprehensive than the current Medicare Act. There is no problem based on what I read off. Okay. There's a subsection here on override of standards. A, in general, an individual's treating physician or other healthcare professional authorized to exercise independent professional judgment in implementing a patient's medical or nursing care plan in accordance with the scope of practice, licensure, and other law of the state where items and services are to be furnished may override practice standards established pursuant to Section 201A or practice guidelines described in paragraph 1, including such standards and guidelines that are implemented by a provider through the use of health information technology such as electronic health record technology, clinical decision support technology, and computerized order entry programs. So this clause gives the freedom to doctors to use their best judgment to override written standards and guidelines to prescribe something that they think is going to work in order to benefit a patient. So this is very important. But then there's a subsection B of the limitation. An override described in subparagraph A shall, in the professional judgment of such a physician, nurse, or healthcare professional, be consistent with the physician's, nurses, or healthcare professionals' determination of medical necessity and appropriateness or nursing assessment. So it gives this power to override to nurses as well. 2, in the best interests of the individual, and 3, consistent with the individual's wishes. So this provides considerable freedom to get out of straitjackets, both to individuals and to physicians and to nurses, healthcare professionals. Now we're at Section 204, coverage of long-term care services. A, in general, subject to the other provisions of the Act, individuals enrolled for benefits under this Act are entitled to the following long-term services and supports, and to have payment made by the Secretary to an eligible provider for such services and supports, if medically necessary and appropriate, in accordance with the standards established in the Act, for maintenance of health or for care, services, diagnosis, treatment, or rehabilitation that is related to a medically determinable condition, whether physical or mental, of health, injury, or age, that 1, causes a functional limitation in performing one activities or more activities of daily living, or requires a similar need of assistance in performing instrumental activities of daily living. B, eligibility. An individual shall be eligible for services and supports described in this section if such individual has one or more medically determinable conditions described in subsection A. Services and supports. Long-term services and supports under this section shall be tailored to an individual's needs as determined through assessment, and shall be defined by the Secretary include any long-term nursing services for the enrollee, whether provided in an institution or in a home and community-based setting. So, nursing home services, your own home-based services, and community-based settings, of various kinds. For example, I live in a senior development, and we all have apartments. It's not, strictly speaking, an institutional setting. It's a community-based setting. Okay, and what this act is saying is that we can get long-term nursing services for ourselves here, okay, in this building, in our own apartments, okay, our homes, in the community. 2, provide coverage for a broad spectrum of long-term services and support, including for home and community-based services and other care provided through non-institutional settings. It provides coverage that meets the physical, mental, and social needs of recipients while allowing recipients their maximum possible autonomy and their maximum possible civic, social, and economic participation. It also prioritizes delivery of long-term services and supports through home and community-based services over institutionalization. 5, unless an individual elects otherwise, ensure that recipients will receive home and community-based long-term services and supports as defined in subsection F4, regardless of the individual's type or level of disability, service need, or age. 6, be provided with the goal of enabling persons with disabilities to receive services in the least restrictive and most integrated setting appropriate to the individual's needs. 7, be provided in such a manner that allows persons with disabilities to maintain their independence, self-determination, and dignity. Provide long-term services and supports that are of equal quality and equally accessible across geographic regions, and ensure that long-term services and supports provide recipients the option of self-direction of services from either the recipient or care coordinators of the recipient's choosing. That was number 9, sorry. So, you got to say that's pretty comprehensive and very oriented to keeping individuals in a non-institutional setting for as long as possible during their lives. It's pretty comprehensive in terms of providing service. I'd say more than pretty comprehensive. I'll take the pretty away. It's comprehensive. Okay, there's a section on public consultation with people who know about the kinds of services, okay, that are necessary. I don't think that I have to read through this, but it's there. You know, you can go to it. Okay, it's in the link. Here's a definition. The term, quote, long-term services and supports means long-term care, treatment, maintenance, or services needed to support the activities of daily living and instrumental activities of daily living, including home and community-based services and any additional services and support identified by the Secretary to support people with disabilities to live, work, and participate in their communities. 2, the term activities of daily living, quote unquote, means basic personal everyday activities, including tasks such as eating, toileting, grooming, dressing, bathing, and transferring. Not sure what transferring means here. But that sounds like a pretty basic list. Certainly, more advanced activities, like, for example, cooking, something like that, would also be covered. 3, the term instrumental activities of daily living, unquote, means activities related to living independently in the community, including but not limited to meal planning and preparation, yes, cooking, managing finances, shopping for food, clothing, and other essential items, performing essential household chores, communicating by phone or other media, and traveling around and participating in the community. And then in subsection 4 under here, it refers to a section 1915 of the Social Security Act. as defined by the Secretary. Okay. So there are the whistleblower protections that I won't go through here, but there are those. They are comprehensive. They look to be very good in relation to protecting people. I'm going to scroll down. Here are in Section E, okay, of whistleblower protections. One, retaliation prohibited. No person may discharge or otherwise discriminate any employee because the employee or any person acting pursuant to a request of the employee, A, notified the secretary or the employee's employer of any alleged violation of this title, including communications related to carrying out the employee's job duties. B, refused to engage in any practice made unlawful by this title if the employee has identified the alleged illegality to the employer. C, testified before or otherwise provided information that's relevant for Congress or for any federal or state proceeding regarding any provision or proposed provision of this title. D, commence, cause to be commenced or is about to commence or cause to be commenced a proceeding under this title. E, testified or is about to testify in any such proceeding. Or F, assisted or participated or is about to assist or participate in any manner in such a proceeding or any other matter in such a proceeding or in any other action to carry out the purposes of this title. And there is item 2, enforcement action. Any employee covered by this section who alleges discrimination by an employer in violation of paragraph 1 may bring an action subject to the statute, of limitations in the anti-retaliation provisions of the False Claims Act and the rules and procedures, legal burdens of proof, and remedies applicable under the employee protection provisions of the Surface Transportation Assistance Act. So those were the legal provisions I thought it was important to make you aware of. I'm going to scroll down now until the next part that I wanted to emphasize. This will take us much more rapidly through the Act. Okay, administration, subtitle A, general administration provisions. This is Title 4, Section 401, okay, administration. In general, Secretary shall develop policies, procedures, guidelines, and requirements to carry out this act, including related to eligibility for benefits, enrollment, benefits provided, also provider participation standards and qualifications as described in Title 3, levels of funding, F, of methods for determining amounts of payments to providers of covered items and services. So this is a listing of the things that have to be done in dealing with the providers, okay, that are authorized by the Act, or actually mandated by the Act, okay, in this case. I'll continue to scroll down and go through more of the Act. We are now through the first 50 pages. There is a provision, okay, for an ombudsman in order to handle disputes. There are quality standards to be set. Those are to be implemented and evaluated by the Center for Clinical Standards and Quality, okay, which is a center within the Centers for Medicare and Medicaid Services, which is the administrative arm both for Medicare and Medicaid services, okay, at present. So those centers would carry over, but of course there would be no more traditional Medicare, okay, or Medicaid. There would only be the enhanced form, okay, of Medicare for all specified by this bill. So it would really become the Centers for Medicare for All, or the Centers for Improved Medicare, okay, or Enhanced Medicare. Most likely, that key center that actually administers the act would be given a new name, but it has not been given a new name in this bill yet. It's simply called the center. Okay. There are various ways of addressing healthcare disparities and providing for equality from region to region and local area to local area. There are cost containment measures that are specified in the bill. Okay, I'm not going to go into those, but they have teeth, and they would be very important for cost containment in the bill. They are one of the reasons why we could probably expect national healthcare spending savings of at least 1/3 and maybe more under what we spend at this point for healthcare. Subtitle B is of Section 6, deals with payments to providers. It tells you that that global budgeting will be used, okay, for institutions, fee for services, okay, for individuals. For groups, okay, it will be possible for individuals to be, for groups to be specifying salaries for individuals. And so doctors in groups might be paid salaries and not go by fee for service. Okay, but at this point, I don't read this as being a mandate in the bill. It's something that the groups could elect, and they actually might well do that, because I would suppose that subgroups would have profit sharing arrangements of certain kinds. But anyway, I'm not going to go through the payment amounts here, okay, but you can check on them. But for yourself, they are designed to cut down on total costs, okay, of the program. Of course, the program will be negotiating with the manufacturers of pharmaceutical products to make sure those will be priced as reasonably, okay, as possible. I did want to highlight one section here, or one subsection here, under costs, and that's section D. Costs for infectious disease response preparedness, including maintenance of a 1-year, 365-day stockpile of personal protective equipment, occupational testing and surveillance, medical services for occupational infectious disease exposure and contact tracing. Costs for that are explicitly written into the bill and will be negotiated, and imply that in the future there will be no shortage of PPE equipment, okay, available, and no shortage of occupational testing. That the kinds of situations we had when the pandemic started off here are being planned for in this bill, and were part of the changes that were devised for this particular bill. going on. Here are prohibitions which apply to payments. Payments to providers under this act may not take into account, include any process for the provision of funding for, or be used by a provider for, one, the marketing of the provider, the profit or net revenue of the provider, or increasing the profit or net revenue of the provider, incentive payments, bonuses, or other compensation based on the utilization of items by patients or services by patients, or any financial measure applied with respect to the provider or any group practice, integrated healthcare delivery system, okay, or other provider with which the provider contracts or has a pecuniary interest, including any value-based payment or employment-based compensation. Okay. In other words, the profit motive is to be largely excluded from this particular program. These will be nonprofit arrangements, which probably means that a low level of profit is going to be allowed and will be negotiated with the federal government, but nothing, it will be like not-for-profit businesses or nonprofit businesses are today. There will be fees, 6% or something like that, or 10%. So, what the Medicare for All system will do is to wash out the profit incentive that now exists in the healthcare system and that causes the inefficiencies we now see in the United States alone as compared to other advanced countries in the world. So, okay, here's another limitation. The Secretary shall not grant funding for capital expenditures under this subsection for capital projects that are financed directly or indirectly through a diversion of private or other non-Medicare for All program funding that results in reductions in care to patients, including reductions in registered nursing staffing patterns and changes in emergency room or primary care services, okay? Neither primary care services or availability of emergency room services. And for Secretary shall not grant funding for capital assets not, well, item 4 is capital assets not funded by the Medicare for All program. Operating expenses and funds shall not be used by an institutional provider receiving payment for capital expenditures under this subsection for a capital asset that was not funded by the Medicare for All program without the approval of the regional director or directors of the region or regions where the capital asset is located. So in other words, if an organization now has a capital asset that was not funded by the Medicare for All program, then there will be no funds from the Medicare for All program that will be forthcoming to maintain that capital asset or to enhance that capital asset. That is not going to be allowed without the approval or the regional director, okay, or directors of the region or regions where the capital asset, okay, is located. Also, the next section D or subsection D is a prohibition against commingling the operating and the capital funds. Well, there'll be a separate budget for operating expenses and a separate budget for capital funds, and the two budgets will never be mixed. Okay, there's a clause on payments for special projects. In general, the Secretary shall allocate to each regional director for amounts made available for special projects pursuant to Section 601 A to C. Such sums are determined appropriate by the Secretary for purposes of funding projects described in such section, including the construction by renovation or staffing of healthcare facilities in rural, underserved, or health professional or medical shortage areas within such a region, and to address health disparities, including racial, ethnic, national origin, primary language use, age, disability, sex, including gender identity and sexual orientation, geography, or socioeconomic health disparities. So special projects for addressing health disparities. That's what this is about. Each regional director shall, prior to distributing such funds, in accordance with paragraph 2, present a budget describing how such funds will be distributed to the Secretary. There's a prohibition on financial incentive metrics in payment by determinations. Secretary may not utilize any quality metrics or standards for the purposes of establishing provider payment methodologies, programs, adjustments for provider payments under this title. So the Secretary is not getting into any special payments that are due to what is shown by quality metrics. I suppose but they're assuming is that whatever quality metrics are employed by people in the program will be rewarded in terms of successful services to the patients, and that good quality health care essentially gets rewarded through success itself and not by any additional payments. I'll scroll down some more. There's a lot of attention that's given to try to equalize services, across to the United States. There are provisions for Indian healthcare programs and for TRICARE, and for veterans, and they relate to people in these programs having options to stay in these programs, or to come over to Medicare for all. I'm not going to go into those at this point because time is definitely running out. At this point, there's a prohibition, on anti-competitive behavior in the bill. And there is reporting by the pharmaceutical manufacturers to disclose such information that the Secretary determines would be necessary for carrying out the mandate, of this section, that there won't be any anti-competitive behavior. In other words, no monopolistic behavior, is allowed. Now we come to Title VII, which is the Universal Medicare Trust Fund. This is important because we so far have not come to anything in this bill that deals with the question of how you're going to pay for it, okay, in any way. Okay. I don't really care myself about that question because I know, well, I care about it, okay, in the political sense, but I don't care about it from the point of view of thinking, well, the federal government is not going to be able to pay for it. I'm sort of one of the experts on the various options that the federal government can use to pay for anything that it chooses to pay for. So that's not, okay, an issue here. But of course, I look for pay-fors in these bills to see if things are earmarked, okay, in such a way. So Section 701. In general, there is hereby created on the books of the Treasury of the United States a trust fund to be known as the Universal Medicare Trust Fund, in this section referred to as the, quote, trust fund, unquote. The trust fund shall consist of such gifts and bequests as may be made, and such amounts as may be deposited in or appropriated to such trust fund as provided in this act. Now, thus far, it doesn't talk about the various sources of the amounts that may be deposited in such a trust fund. By the way, it's not very explicit on what it means by deposited in. In the trust funds that have existed so far, there are no funds that are deposited in those trust funds. Those so-called trust funds are merely accounting records of what the Treasury owes these trust funds. The actual reserves always stay in the Treasury general account or other Treasury accounts. And they're not, for example, in any bank accounts owned by Social Security or any bank accounts owned by Medicare. Okay. Next section deals with appropriations into the trust fund. 1. Taxes. There are appropriated to the trust fund for each fiscal year, beginning with the fiscal year which includes the date on which benefits first become available, as described in Section 106. So again, when, let's say, an act was passed in 2021, July of 2021, then the first benefits would become available in July of 2022, which is in fiscal year 2022. It's towards the end of that fiscal year, but it is in that fiscal year. The fiscal year begins on October 21st, 2021. So appropriations to the trust fund would have to be made in at the beginning or in advance, actually, of the start of fiscal 22. In other words, by the end of September, or if there was some kind of funding crisis again, sometime in October, there would be appropriations to this trust fund if we assume the act might be passed in July. So as soon as that, we would have an appropriations battle over what was going to go into the trust fund. Okay. As described in Section 106, out of any monies in the Treasury, so there are appropriated out of any monies in the Treasury not otherwise appropriated, amounts equivalent to 100% of the net increase in revenues to the Treasury, which is attributable to the amendments made by sections 801 and 902. So let us go up here. We're still in section 701. So we haven't encountered sections 801 or 902 yet. So we have to get to those to see what this actually means. All right. The amounts appropriated by the preceding sentence shall be transferred from time to time, but not less frequently than monthly, from the general fund in the Treasury to the trust fund. So what that means in practice is that what the Treasury will do will be to credit the trust fund trust fund with an amount that the Treasury owes it. It would be a purely paper credit, okay, that was given to the trust fund. There would be no dollars transferred from the general fund in the Treasury to the trust fund, because the trust fund isn't going to be a bank account. None of them are bank accounts. So reserves cannot be transferred to them. What can be transferred to them is an accounting record of how much is in this trust fund. As we shall see later, what will be transferred to the trust fund, okay, as soon as the benefits that will be paid out, will be the amounts in the old trust fund. So let's say the old trust fund was, let's say, that $3 trillion, I'm sorry, that, okay, let's say $1 trillion was in the Medicare trust fund at the time of the first payout, okay, benefits. Then before the benefit, the payout, the new trust fund, what's called here the quote trust fund, unquote, would get its first so-called injection, okay, of dollars. In other words, it would be credited with the $1 trillion, or however much of it was no longer needed by conventional Medicare. I don't think any of it would be needed by conventional Medicare, because in July of 2022, everybody over 55 would be covered, which means everybody who was on Medicare. So the Medicare trust fund then would be zeroed out, and the amount that the Treasury owed to the Medicare trust fund, it would now owe to the new trust fund. Okay. So here it says, such amounts to be determined on the basis of estimates by the Secretary of the Treasury of the taxes paid to or deposited into the Treasury, and proper adjustments shall be made in amounts subsequently transferred to the extent prior estimates were in excess of or less than the amounts that should have been so transferred. So I'm not entirely sure what that means, but in my interpretation, what it means is that what the Secretary would do is to estimate what had been collected in taxes and was in the general fund. Of course, we know that, in fact, no taxes are actually in the general fund, because those tax revenues are canceled out in the process of settlement, and new money, the new reserves, okay, are then created for the Treasury general account by the Fed. But still, the Secretary of the Treasury will pretend that tax money was deposited into the Treasury account, and the Secretary of the Treasury will make estimates, okay, of that. Okay, and make adjustments as necessary. So that's for the category of taxes. Then there's also current program receipts, okay, for the initial year, notwithstanding any other provision of law. There is appropriated to the trust fund for the fiscal year containing January 1st of the first year following the date of the enactment of this act, an amount equal to the aggregate amount that was appropriated for the preceding fiscal year for the following: increased by the Consumer Price Index for all urban consumers for the fiscal year involved. The Medicare program under Title 18 of the Social Security Act, other than amounts attributable to any premiums under such title. The Medicaid program under state plans, the Federal Employees Health Benefits Program, the Purchase Care component of the TRICARE program under Chapter 55, the Maternal and Child Health Program under Title 5 of Social Security, and then it goes on and lists all of the programs that will be getting receipts. And it says those are going to be appropriated to the trust fund for the fiscal year containing January 1st. So that fiscal year will be fiscal year 2022. So that will all be appropriated to the trust funds, which means that the Treasury will owe those amounts to the trust fund, which it will then pay back as payments are due, supposedly from the trust funds. So then in subsequent years, notwithstanding any other provision of the law, there is appropriated to the trust fund for the fiscal year containing January 1st of the second year, following the date of the enactment of this act, and for each fiscal year thereafter, an amount equal to the amount appropriated to the trust fund for the previous year, adjusted for reductions in costs resulting from the implementation of this act, changes in the Consumer Price Index for all urban consumers for the fiscal year involved, and other factors determined appropriate by the Secretary. So basically, what I make of that is that what is collected for the trust funds based on withholding will be appropriated to the trust funds. And it will be up to the Treasury to find money for these appropriations using the various devices that Treasury has been empowered by Congress to use to fill the Treasury general account to meet with those particular appropriations. So that's what I make of that. Subsection D says transfer of funds, any amounts remaining in the Federal Hospital Insurance Trust Fund under Section 1817 of the Social Security Act, or the Federal Supplementary Medical Insurance Trust Fund under Section 1841 after the payment of claims for items and services furnished under Title 18 of such act have been completed, shall be transferred into the Universal Medicare Trust Fund under this section. Don't worry, though, I don't think any amounts will be remaining in the Federal Hospital Insurance Trust Fund. Okay. Does this language, here's a key question, does this language say that the appropriations that are needed for the Medicare for All program will have to be paid for by tax revenues? I don't read it that way. I don't read it in that way at all. The way I read it is that the funds that come to the Treasury General account from the withholding for Medicare for All will get into the Treasury General account in the usual way through settlement and through creation of new dollars by the Federal Reserve for the Treasury General account. The Treasury will continue crediting the trust fund, in the way it's been doing with essentially electronic credits, which it will reduce when it actually spends the money that it must spend to provide the benefits to the recipients. So what Treasury will be doing is all through fiscal 2022, it will be crediting the trust fund, with electronic credits. It will be continuing to get reserves from the Fed as a result of the settlement process of the withholding. But these reserves will continuously top up the Treasury General account. When the time comes to spend, on benefits in fiscal year 2022, that is in July of 2022, it will begin to spend on the benefits. But as it spends, it will debit the trust fund. The trust fund will have been augmented at first by the transfer of the old trust funds into it. If any shortages come up in the trust fund, then it seems to me Treasury can use its usual techniques for handling the shortages. Its usual techniques include issuing debt instruments, which in terms of the settlement of debt instruments, the same thing happens, as in tax settlements. The money is destroyed by the Fed in the process of settlements, but new reserves, are created then for the Treasury General account. So there's plenty of money from that coming into the Treasury General account. But if there are any shortages from taxing, and from selling debt instruments, or if the Treasury simply wants to, it can mint some platinum coins to cover any deficit spending which occurs. By the way, it won't be clear whether the deficit spending is coming from as a result, okay, of Medicare spending, okay, or as a result of the military spending that we do, okay, or as a result of any other kinds of spending, okay, that we do. The only thing we'll really know is that the federal budget, okay, is in deficit, and that deficit spending is not actually reducing the balance in the Treasury General Account, because the Treasury General Account is being augmented through the sale, okay, of debt instruments, which is triggering the Fed to create new reserves in the Treasury General Account, or because, okay, it's the Treasury has chosen to issue some platinum coins to augment it, or perhaps because the Congress will do something intelligent for a change, okay, and before the year even starts, okay, will determine that the Treasury is likely to need so many dollars for the year, and simply orders the Federal Reserve to place that volume of newly created reserves in the Treasury General Account on the first day of the new fiscal year. That technique, by the way, is known as overt congressional financing, and I've written about it on my blog. So there are various ways it can be done, but I don't see anything in this bill that mandates pay-go, at least not yet, and I am on page 96 at the time. So here we go. Actually, I was on page 101. There's something here on federal retirement programs too. These are conforming amendments to make the Medicare for All bill consistent, okay, with other bills. I'm not going to go through the conforming amendments. What I did want to do was to deal with the transition programs, and I have some things on that. Title 10, the transition. Subtitle A, the Medicare for All transition over 2 years and transitional buy-in option. Transition. In general, every individual who meets the requirements described in paragraph 3, that's way back at the beginning, shall be eligible to enroll in the Medicare for All program under this section during the transition period starting 1 year after the date of enactment of the Medicare for All Act of 2021. So this is a public option. Okay, this is a public option. 2 benefits. An individual enrolled under this section is entitled to the benefits established under Title II of the Medicare for All Act of 2021 if the individual meets the eligibility requirements established by the Secretary under Title I of the Medicare for All Act of 2021. In other words, people who are from 0 through 18 and 55, okay, and over, okay, they're entitled to the benefits, okay, of Medicare for All. But also starting in 2021, there's a Medicare in Section 1002. There's a Medicare transition buy-in. That's what I meant when I said there was a public option. To carry out the purpose of this section for the year beginning 1 year after the day of enactment of this act, and ending with the effective date described in Section 106A. The Secretary, acting through the Administrator of the Centers for Medicare and Medicaid, shall establish and provide for the offering through the exchanges an option to buy into the Medicare for All program. In this act referred to as the Medicare Transition Buy-in. The Administrator shall administer the Medicare Transition Buy-in in accordance with this section. Application of Affordable Care Act requirements. Consistent with this section, the Medicare Transition Buy-in shall comply with the requirements under Title I of the Patient Protection and Affordable Care Act and the amendments made by that title, and Title 27 of the Public Health Service Act of Section 42 of the U.S. Code, 300 GG, et sec, that are applicable to the qualified health plans offered through the exchanges, subject to the limitation under subsection E2. So there's an offering of the buy-in through the exchanges, and that shall be available to individuals wishing to enroll and to qualified employers who wish to make such a plan available to their employees. Any United States resident may enroll in the Medicare Transition Buy-in. The benefits under this have an actuarial value or are required to have one. Coverage for the benefits to be required to be covered under Title II of this Act, and 2, coverage of benefits that are actuarially equivalent to 90% of the full actuarial value of the benefits provided under the plan. So, people will be able to buy in, and the administrator shall reimburse the providers at rates that are determined for equivalent items and services under the Medicare for All fee-for-service schedule established in Section 2012B of this Act. Any payment rate under this subsection for a prescription drug shall be at the prices that are negotiated under Section 616 of this Act. A healthcare provider that is a participating provider of services or supplier under the Medicare program under Title 28 of the Social Security Act, or under a Medicaid plan under Title 19 of such act on the date of enactment of this act, shall be a participating provider in the Medicare Transition Buy-in. So, this will be cheaper than private health care plans. They'll be basically at cost. The administrator is going to determine the premium amount for enrolling in the Medicare Transition Buy-in, which may vary according to family or individual coverage, age, and tobacco status. So this will be a cheaper plan than is currently available to the Affordable Care Act people. How cheap, it's hard to say. That's going to be up to the Secretary, but it's probably going to be a good deal cheaper, and it will be much, much easier for people who don't have insurance now and who won't be getting insurance in that first year to get fairly economical insurance. The details are important, of course. We don't know what the details will be under this particular section yet, but there is at least some guidance that this is going to be a very, very good benefit, because later on there is a table that specifies, in the case of a taxpayer who's covered, or whose house, the spouse or dependent is covered by the Medicare Transition Buy-in established under Section 1002A of the Medicare for All Act of 2021 for all months in the taxable year. The applicable percentage for any taxable year shall be determined in the same manner as under Clause 1, except that the following table shall apply in lieu of the table contained in such clause. In the case of a household income expressed as a percent of the poverty line within the following income tier, if your income is up to 100%, okay, of the poverty line, then the premium percentage is going to be 2.0%, the 2.0% of your income. The final premium percentage is going to be 2.0%, okay, of your income. If you're in the group from 100% up to 130%, it will be 2.04% of your income, the initial premium, in other words, at 100%, and at just over 100%, and the final premium percentage will be 2.04%. If you're in the 138% of poverty up to 150% of poverty, then your premium percentage will be 3.06%, and your final premium percentage will be 4.08%. So still fairly low. And 150% and above poverty, your initial premium percentage will be 4.08%, and the final percentage will go up to 5%. So that will be a maximum of 5% for anybody who wants to buy into the Medicare transition plan to buy into the Medicare transition plan. So since the Medicare transition plan is going to involve things like co-payments and prescription drugs and things like that at cost, it seems like a premium of 5% of income, especially for those 150% and above, would be a good deal and would entice people to buy into the Medicare transition plan. It's not going to be as great, okay, as a Medicare for all they'll be entitled to after the second year. But it's going to be much better than what they're now entitled to under commercial insurance, and especially so if they, okay, are poor. It's probably something people will find it much easier to buy into than we see now.
It still has to be voted on.
Bonnie says it still has to be voted on. Well, okay, of course. There's another subtitle here, subtitle B, for the transition. What it says is that eliminating the 24-month waiting period that's in Section 1011 for Medicare coverage for individuals with disabilities. So if you have a disability, you're going to be eligible from the first, with the first people, okay, who are eligible. You will be eligible for Medicare for all coverage. I believe that's what it says. Then there are miscellaneous definitions. I'm not going to go over those, okay? I'm going to leave them to you. So that is what the bill provides. Okay, it certainly seems to be a very, very good bill. Now, I hope to have time today to talk about the politics, okay, of this, specifically the deconstructed article by Ryan Grimm dealt very much with the politics of it, and is very well worth going over. But we've been at this for 2 hours now, and you have a lot of questions. So I'm going to turn to your questions. Okay. I promise the next live stream that I do will be on the politics, because people have been saying that this is purely performative, because they think the fate of the Medicare for All bill is predetermined, because first of all, there's considerable opposition in the House, okay, of Representatives. So far, only 113 co-sponsors, okay, and even though this is more than half the caucus now, and that wasn't the case in 2019, they didn't have half the caucus then, there are still people who think that it's going to be impossible to get this passed through the House, because you'll never get by the opposition, who are insisting on enhancing the Affordable Care Act. That, okay, is very likely true, but there still may be opportunities to force the vote on this. One of the things that I'm going to go into when I do the live stream on the politics of this is that I will go into how force the vote might actually be accomplished, okay, in the House. And I'll also give some reasons for possibly thinking that maybe the Medicare for All bill has a chance if the progressives actually are able to force the vote. One reason why it might have a chance to get out of the House, just to give you a preview, is that 88% of Democrats in the country favor the Medicare for All bill. And House members don't want to go on record as being against it. They don't want to be saying, I don't support Medicare for All. And that will become increasingly unpopular as the progressives in the House and in the country start to pressure. But also, secondly, the existence of the filibuster in the Senate actually works the other way in the House, because the way the filibuster works now, and is working now, and as long as it continues to exist in the Senate, then the House members will pass some bills that they're not serious about, because they think those bills will be blocked in the Senate. So, having said that, I'm now going to turn to your comments, and we will end for tonight after I entertain your comments. So, Greg Mallard says, good evening, Joe and everyone. And Kay says, shared. Greg Mallard says, did you all hear about a volcano in Iceland that erupted?
Yes.
No, I did not as yet, but Bonnie says yes. Terry says, saw the headline. Is it catastrophic? Kay says, I did. Greg Mallard watched a good report on it. Greg says, I just shared it on my page from a local meteorologist. They said the lava flow could be seen from 20 miles away. Oh, wow. And Terry says, open smart news and read the IRS commissioner told lawmakers child tax credit payments may not be issued monthly and may start in July. Here, to read it on the web, tap here. Oh, that is stupid. After all the hype about those child tax credit payments, they better start making those payments. They better start. Terry Burke said, Gregory Mallard, new land being born. Kay says, I watched an hour and a half live stream on the Medicare for All rollout. Very good. Yeah, that was the town hall I was talking about. There's Nikki King. Hi, Nikki. Terry says hi. Kay says, the Medicare for All would have helped my Scott, to live. And I heard a report at least 1/3 of the pandemic deaths could have been saved too. I personally think that's an underestimate. I think between Medicare for All and handling of the pandemic, in the way New Zealand did or Taiwan did, I believe we could have saved 99% of U.S. fatalities here. Instead of having what looks like it's already at 560,000 fatalities, unless I'm exaggerating a bit, we might have had more like 5,600 fatalities in the United States. Greg says it could have saved even more lives than that. Troy says, I'm late, but here. Hiya, Troy. Kay says, how about us old bags are already on Medicare? We're already on Medicare, but remember, Medicare is nowhere near as good, as Medicare for All. There's a world of difference between the two. Evelina says, just found you, yay. Kay says, I hate having to deal with the financial crap that goes along with Medicaid. And you wouldn't have to deal with that under Medicare for All. Anthony says, biological products, cool. Terry Burke says, vitamin D3 is a biological product. Vitamin D3 is. I spend a lot on vitamin D3 each month. Kay says, my Scott was in hospice care until he died. They took good care of him. Evelina says, over-the-counter vitamins not included, I guess. Well, they're biological products. If your doctor prescribes them, I don't see why they wouldn't be included. And Troy says, okay, I'm over here now till my internet at work messes up. Terry says, therapeutic massages should be added as a preventative under Medicare for All and saunas. Yes, they should. They definitely should. And saunas should as well. If we get the GOP in control again, can they cancel it all, Joe? They can absolutely poison it. So much is based on decisions that the secretary makes that if the kinds of Republicans we have in office now get control of it again, yeah, they can put big, big holes in it. There's no law that can't be sabotaged by a political party that wants to sabotage it. For a while, for a long time, until we see a reformed Republican Party fully in back, of Medicare for All. If we want Medicare for All, we must never vote for Republican control until they totally change. Until they go back to the Eisenhower Republican Party, they cannot be trusted with a Medicare for All program. They cannot be trusted with Social Security. Look, they've been trying to undermine Social Security for years and years and years. Terry Burke says no. Terry Burke, if it's a state policy like in Britain and other places, then it can't be eradicated. but alas, it's only administrative. That making it probably can be canceled. No, the Medicare for All program here will be a state policy. That doesn't mean that it can't be sabotaged by administrative rulemaking. I mean, look, even in the UK, they've been sabotaging the National Health Services for years and degrading the level of care. I mean, people in the UK know that. They haven't been able to do that much of it because it's so popular, okay, in the UA, but they do every little bit they can get away with. Cases, that was why I asked Evelina. Evelina says, meaning, not making. Kay says, my old Facebook friend who was an RN in the UK's NHS told me they have been trying to cancel services there, but so far it hasn't worked. Yeah, it would be too politically unpopular there. It is too politically unpopular, but they've been underfunding it in the UK. And the Conservatives have been underfunding Medicare for All in Canada. They try to underfund these programs whenever they get into power. If you really want to defend programs like this, you must almost never put those people in power. Evelina says the GOP would underfund it, then undermine it permanently, is my guess. They would try. Terry says physical therapists should have that override empowerment as well. Yes. Kay says that is what they've been doing in the UK. Evelina says become part of their DNA. Hard to take it out completely, but I think the Conservatives are underfunding the NHS. Me too. And Terry says, how about home doctor visits like in Europe? Well, I think we would have to have those here. I mean, wouldn't we? If they're going to provide home care, how can they provide home care for people who can't go out of their homes? Some doctors may have to make house calls again. Kay says it's sad that seniors have to give up everything now to get the nursing homes paid for by Medicaid. It is. Evelyn says so should psychotherapists, but I don't know. Evelyn said those are great. We have them in Argentina. Kay says that would be great, Evelina. Yeah, I think psychotherapists will be covered or are covered under Medicare for All, as I interpret the law. Terry Burke says it's what the military has, medical care. Evelina, on the hunt a good or bad entity. Evelyn says, sounds like a good bill, but will it pass? That is the question. It is a really good bill. It's going to be a rough fight, though, to get it passed. Alex Topolsky says, I'm a gig worker. I've not had health insurance for over 12 years now. Keeping a roof over heads for 6 months equals 1 month of good health insurance. Yes, Alex, under Medicare for All, you would be covered. Kay says, that is the question, Evelina. Sadly, none of our good Dems have stepped up to sponsor the bill. Shake my head. I hate Ohio. Not only that, Kay, Tim Ryan, who's been a supporter, Kay, of Medicare for All for years now, and was a supporter of H.R. 1384, has refused to co-sponsor H.R. 1976 because Tim Ryan is looking to run for the Senate. And he believes that if he's a co-sponsor of H.R. 1976 in the House, that he's less likely to be nominated for the Senate, okay, in Ohio. He wants to run for that open seat that you have, okay, in Ohio. So he won't co-sponsor the Medicare for All bill. On the other hand, if he doesn't run for the Senate, it's very likely he would vote for the Medicare for All bill because it's very likely he would stay in the House. Lana says, if anyone has questions, feel free to type them here. Dr. Joe usually reads the comments and responds at the end. Kay says, Ohio actually has our own single-payer network of activists, and I belong to the Facebook group. Evelina says, profits is right. Laugh out loud, Freudian slip. We're faithless, haha. Evelina says, does sound too good to pass. And whatever, man, I don't know who is whatever, man, but he says, why doesn't Biden just give M4A under the provision of Obamacare? I forget. Okay, I forgot what provision it was. There is a provision that allows him to give Medicare to everybody, not this version of Medicare, but the current version of Medicare to everybody. There's an emergency provision that's in the Affordable Care Act. Okay, and Max Borkus got it put in for people in a specific town in Montana that were victimized by work in the mines, okay, in the coal mines. And he arranged for them under this emergency provision to get free medical care for the rest of their lives. But when the bill passed, okay, it declared, okay, an emergency for this particular town. But it also contained a provision saying that the secretary can declare other emergencies. So, in other words, it's possible for the secretary to declare that under the emergency caused by COVID-19, that the whole country is eligible for the kind of care that was afforded to the Montana people. There is a provision on that. Biden is never going to do it. Lana says, that sounds like the bill excludes the kickbacks from pharma, etc. Good. Yes, it does sound like that. And Evelina says, flash out the profits incentive, yes. And Kay says, Evelina, how long have you been down there? Evelina says, flush out profit incentives. Evelina says, since George Bush. Evelina says, Junior. Balana, whatever man says, do you work in banking? And Kay says, hope we can fix this country so you can come back. I'd love to meet you face to face, honey. And Lana says, yes, I do. Why do you ask? And whatever says, oh, what is your opinion on public banks? And Russell says, does this even stand a chance, Kay, of getting anywhere? I think that depends on politics, Russ. It depends on politics. It depends on the noises we make. Okay, it depends on how people signing on for co-sponsorship goes. It depends on various campaigns to force the vote in various contexts, which means it depends on first forcing the House to vote for it, because 80%, 88% of Democrats are for it, and they all get worried about primary challenges if they don't support it. So the first job is getting the House to pass it. But while we're doing that, even before we're doing that, we have to make sure that we get rid of the filibuster in the Senate, or if not get rid of it, severely modify it, so that if the bill does get out of the House, it can be passed in the Senate by majority vote. Because the same thing applies to the Senate as the House. If we're talking majority vote and we're talking getting a floor vote, and we're talking about 88% of Democrats being in favor of a Medicare for All bill, then there's a chance of passing it through the Senate. The question is when. Evelina says, saw the towers fall on TV just a year after I arrived. I sensed something awful would happen under him. Evelina, I don't know if that's a smile or a frown, Evelina. Can't see it in my interface. And Kay says, yep, they knew it was coming and did nothing. Kay says Cheney got rich and still is getting richer under the endless wars over there. Yeah, Cheney is real rich. Lana says at WM, I am more for public banks than against. Too many people don't have the cash flow to maintain a regular bank account. I like postal banking. Postal banking is all over Europe. And whatever man says, that's what I'm focusing on, Lana. And whatever man says, public postal banking. Evelina says, horrible man. Yes, he is. Terry Burke said, they did mention taxes several times, which will give the GOP ammo to fight against it. So the tax terminology needs to be taken out, which leaves us on the subject of how we can get rid of the GOP and establishment Democrats once and for all. Now, the tax terminology doesn't need to be taken out. It doesn't specify any increase in taxes beyond what taxes we have now. And by the way, there doesn't have to be any increase, in taxes. And by the way, people are going to spend a whole lot less for Medicare for all than they are now currently spending. That is the bottom line. This is going to save huge amounts of money for people in the aggregate and, as individuals. Now, we do need to prevent any kind of pay-go provisions in this particular bill. We do not need to have some special tax provisions so that the Medicare for All bill is deficit neutral over 10 years. We need to get rid of that bullshit. I mean, no provision of that kind, is in any of our military spending bills, and there's no reason why any provision of that kind should be in our healthcare spending bills or in any bills. Let the Congress levy the taxes it needs to levy to contain inflation. That's one of the purposes of taxation. Other purposes involve sin taxes and taxes to protect our democracy. Those are the main purposes of taxation. But taxing for revenue is not a main purpose, and we must stop things from getting put into legislation that say it has to be deficit neutral. Not saying that the Medicare for All bill won't be deficit neutral. I'm saying stop this BS of having CBO score things for deficit neutrality over 2 years. That is bullshit. Lana says, here is the MMT Fed and Treasury lesson. Whatever man says, I need an MMT monetary policy lesson, laugh out loud, re-QE. Well, the MMT has things to say with respect to monetary policy, but the preferred monetary policy, of MMT is to have zero federal fund rates all the time and leave things to fiscal policy. And as far as QE is concerned, that has to do with the Federal Reserve seeing to it that there's plenty of reserves in the system to keep the system flowing, and liquid. And it has to do with maintaining zero interest rates, which is the preference for MMT-based type, of monetary policy. MMT-based the fiscal policy is very different, though. And according to MMT, the main way of managing the economy would be through fiscal policy and through regulation, of various kinds. And not through monetary policy at all. Evelina says, what did Evelina say? I scroll down too fast. It's all about politics, isn't it? It is. Even when it says, looking to your show on forcing the vote, Dr. Joe. Terry says, definitely GOP will go after this just on the fact that it allows abortion, and you already know they won't relinquish their power, um, um, their power over women. Yeah, well, it seems to me that they're going to oppose this, whether it allows abortions, okay, or doesn't allow abortions. Because if this is passed by a Democratic administration, people, okay, are going to love it, and the Republicans are going to have a hard time winning anything anytime soon if the Medicare for All bill, this Medicare for All bill, is passed by a Democratic administration in Congress. Then the Republicans can hang it up for an extended period of time. That's why they're going to oppose it. They'll scream abortions, but that's only an excuse. They're not opposing it because it allows abortions. They're opposing it because it will be so popular that they'll go through another period like 1932 to 1952, when all they won at the federal level was a single Republican Congress in the period 1947 to 49. The only time they controlled anything in Washington for 20 years. Evelina Pond says, interesting twist. We shall see, won't we? Evelina says, Terry Burke, it's always been like that, though. They've always been against it. Nothing new. Lana says, is there a better way for the bill to discuss funding besides a trust fund? I hate trust funds. Just sets up ongoing fights about being insolvent. Of course there's a better way. You know what it is, Lana. They could have provided the funding for this bill a year in advance by using overt congressional financing, or by specifying that the Treasury General account would be topped up each year for the amount of the estimated appropriations that would be needed, and that it would be topped up through using a platinum coin. They could fund it in that way. The same way Rashida wants to fund the monthly payments for COVID. The Medicare for All bill could be funded in that way. I mean, you know that. I had a blog post on it. And Terry says, if Trump would have acted without their election on COVID, it would not have mutated as much in the U.S., or rather vaccine doses would have been finished being administered, but to the majority of the population. If he had a plan for manufacturing quickly and plans for distribution, for quick distribution, yeah, that all would have been greatly helped. Or if he had used the Defense Production Act to make the work go even faster. And whatever man says, so true, Lana, setting up the trust fund is just like the SS Trust Fund, waiting to be raided. No, the SS Trust Fund is not raided. It has never been a bank account. Never been a bank account. It's always just been an accounting record. It is not a trust fund. When you have a trust fund at a bank, there are bank reserves in your account. Your trust fund is in the form of bank reserves in an account. But the federal trust funds are just accounting records. There is no money anywhere. No money in banks anywhere. except very special things like the intelligence agencies have special funds, secret funds in banks, okay, or in cash. And the Treasury Department has the bank reserves. But that's where the bank reserves are. Social Security doesn't have any bank reserves. None of these federal trust funds, so-called, are in bank reserves. So there's no rating going on because there have never been bank reserves. There have never been bank accounts for these other federal agencies. I mean, maybe they got some petty cash. That's it. The Mint has an account at the New York Fed. It's called the Public Enterprise Fund Account. And it can be swept for profits at will. But those profits from the sweeping of the account are then swept into the Treasury General Account at the will of the Secretary, whenever the Secretary wants to sweep the profits, which, by the way, the profits in the Mint account are called the seigniorage, the coin seigniorage. And Lana says at WM, totally agree. Nancy Gosling Blackmore says, thanks for tonight. Thank you for coming, Nancy. Evelina says, I read the Massachusetts Senator Murphy was brought to tears after visiting the migrant the children's facility. If that's Chris Murphy, he's from Connecticut. Okay, if you mean Chris Murphy rather than some state senator, but Chris Murphy is one of the Connecticut senators, and the other senator from Connecticut is Senator Blumenthal. And Evelina says, will he act? Evelina says, can't read Lana's good comments. It's because Lana's watching, she's coming in, she is watching the YouTube version of this. I get to see the YouTube comments and the Facebook comments, and I read them both out to you. Okay, and by whatever man says, what's the blog post? I will look it up for you, and I will leave a comment after the live stream, okay, is over. Evelina says Dr. Joe is a mythbuster. Yes, in fact, I wrote a book on that. Fiscal Myths of the 2016 campaign, by the way, which apply equally well to the 2020 campaign and equally well to the 2022 campaign. I should change the title to Fiscal Myths of Political Campaigns. And Case says, Biden needs to fire the rump head of SS, by which she means...
Joy.
No, that's the post office. But she means the current head of Social Security appointed by Trump, whom people are pressuring to fire yesterday, which for some reason Trump has not, which for some reason Biden has not done. Okay, I'd love to stop to talk about the politics now, but that's going to take, at least another hour. And I've been on for more than 2.5 hours, already. And so I think it's time to say goodnight. Okay, for tonight. I'll try to fit in a bonus live stream soon to deal with the politics, okay, of the Medicare for All bill. That subject is pretty popular with me. Evelina says Keaton is the pretty myth buster. I think you mean Kelton is the pretty myth buster. But, okay, she may be the pretty myth buster, but in my fiscal myths of campaign 2016, I bust a whole lot more myths than Stephanie does in her deficit myth book. Now, I'm not suggesting that quantity is necessarily better than quality. And you know, I think that Stephanie's book is a terrific book. And she has a talent for expressing things very, very clearly that I think exceeds my talent for doing that. But nevertheless, there's much to be said for quantity. And that book has a lot of quantity for myths. I think I've dismissed something like 45 to 50 myths in there. So remember, that ebook is only $9.99, okay, at Amazon. Some of you might be interested in gambling a stamp. So Dolores says, thank you and good night all. And Kay says, thank you all for a great discussion. Love you all, and we love you, Kay. Carrie Burke says, why did Biden slip 3 times? When did he slip 3 times? Okay, and what do you mean by slip? Did he actually, did he slip and fall? Evelina says, laugh out loud, or did he almost fall? Did he lose his balance? Is he having the kinds of problems Jerry Ford had before he was voted out? Evelina says, laugh out loud. Yes, Evelina, laugh out loud indeed. Anyway, good night, and thanks for coming. Thanks for sharing. And I'll see you soon. I'm ending the broadcast. Oh, Evelina says, stumbled on Air Force One stairs. Didn't Trump do that once or twice? Terry says, getting on the plane. Well, he is 78, you know. We people who are 78 and older, we do have a right to stumble on stairs from time to time, don't we? Now, I don't think I would have stumbled on the stairs. And I'm 82. But I don't really know about that because I rarely do climb stairs these days. I usually just take the effing elevator. Lana says good night. Lana says thanks for the great info. Terry says yes, he sure did. And Dolores says he tripped up the stairs. I'm sure he hates that. When he comes on stage, he always wants to give the impression of the vigorous guy in great shape who can challenge anybody to a push-up contest. Well, I would accept his challenge, but I'd probably need 2 weeks to warm up. So Nikki King says he shouldn't try to run like he did, and yes, they should give him an elevator. Yeah, they should. He's entitled to one. He's 78. If he has to use an elevator, it doesn't mean he can't be president. Right? But Bonnie says, come on. Terry says, I'm not saying it was his age. I think it was his shoes. Good, Terry. I'll buy that. Okay, good night, everybody. It was his